In today's video, we are going to talk about polycythemia.
What is polycythemia? By breaking down the word, we can get a quick definition. Poly, meaning many, cyte, meaning cell, and hemia, meaning blood. So basically, it means that there are many cells in the blood, but in this case, it is predominated by an elevation of erythrocytes or red blood cells. The term polycythemia is used when the hematocrit is elevated of more than 55% in males and more than 50% in females. There are two classifications of polycythemia, namely primary polycythemia or polycythemia vera and secondary polycythemia. Polycythemia vera is a proliferative disorder of the myeloid stem cells. The myeloid stem cells are found within the bone marrow where hematopoiesis occurs. Hematopoiesis are a complex process of the formation and maturation of blood cells. During hematopoiesis, the stem cell then gives rise to red blood cells, white blood cells, and platelets. Polycythemia vera occur at any age, but is more common between 50 and 70 years old. The median age at the onset is 65 years old. Men are more likely to get polycythemia vera, but women tend to get the disease at younger ages. The proliferative disorder of polycythemia vera come from the Janus kinase 2 gene mutation. The cause of the gene mutation is unknown. However, researches are ongoing to whether P. vera may be inherited. How does the Janus kinase 2 gene mutation affect the myeloid stem cells and bone marrow? Normally, the kidneys produce erythropoietin, a hormone that plays a key role in the production of red blood cells. This hormone binds through the receptors of a stem cell from the bone marrow. Once binded, the cell then activates the JAK2 gene and divides, producing red blood cells. With JAK2 gene mutation, the gene is always activated and therefore hyperfunctions. Because there is hyperfunctioning of the JAK2 gene, there is increase of erythropoiesis or red blood cell production, hence increase on red blood cells. Other blood cells such as leukocytes and platelet counts are also elevated in the peripheral blood. As for secondary polycythemia, secondary meaning it is an effect from an underlying condition. These conditions include being on high altitude, heavy cigarette smoking, cyanotic heart disease, obstructive sleep apnea, and renal cancer cause a reduced amount of oxygen. The reduced amount of oxygen acts as an hypoxic stimulant that causes increased erythropoietin production. And when there is increase in erythropoietin production, there is increase in erythropoiesis, hence increase in red blood cells. What is the difference between polycythemia vera and secondary polycythemia? In polycythemia vera, the disorder is directly from the bone marrow where there is increased production of red blood cells. While in secondary polycythemia, there is increase in erythropoietin production that is caused by an underlying condition. When there is increase in red blood cells, this results to increase in blood viscosity and increase in blood volume. When there is increase in blood viscosity and blood volume, there is increase in peripheral resistance, causing manifestation of increased blood pressure. Symptoms from increased blood viscosity may include angina, claudication, dyspnea, and thrombophlebitis. Symptoms also result from increased blood volume and may include headache, dizziness, tinnitus, fatigue, paresthesia, and blurred vision. Erythromelalgia may also occur, which is a burning sensation in the fingers and toes and is only partially relieved by cooling. Generalized itching may also occur, which is caused by a histamine release due to increase in basophils. Other manifestations of polycythemia include ruddy complexion, splenomegaly, and gout and kidney stones. How does splenomegaly occur? When red blood cells get old, are malformed, or damaged, the spleen recognizes them and removes them, as the spleen's main function is to filter blood. However, in polycythemia, the spleen will be filtering more red blood cells, causing enlargement, or what is known as splenomegaly. Gout and kidney stones also occur as there is increase in blood viscosity and volume. The kidneys would have a hard time filtering blood and eliminating uric acid. Elevated uric acid could then result to gout and renal stone formation. Patients with polycythemia has an increased risk of thrombosis, which may cause stroke or myocardial infarction. They also have an increased risk for bleeding and myelofibrosis. How does polycythemia evolve to myelofibrosis? The hypercellular bone marrow, where it produces more than normal amount of blood cells, can only extend 10 years or more. Over time, the bone marrow may become fibrotic that it can no longer produce blood cells. This process is referred to as the spent phase, which may then evolve to as myelofibrosis. What are the diagnostic and laboratory procedures for polycythemia? Complete blood count. This will show an elevation of red blood cells, also elevation of white blood cells and platelets, elevation of hemoglobin, and elevation of hematocrit. Bone marrow aspiration and biopsy may also be ordered as confirmation for polycythemia. Janus kinase 2 gene testing may also be ordered, as about 95% of people with polycythemia vera have this type of mutation and would test positive. What is the medical management for polycythemia? Phlebotomy is an important part of therapy where it involves removing enough blood of initially 500 ml once or twice weekly to reduce blood viscosity. The target of phlebotomy is to maintain hematocrit level of less than 45%. Hydroxyurea may also be prescribed. This is an anti-neoplastic agent to suppress the bone marrow. Anagrelide may also be prescribed. This inhibits platelet aggregation and has been used to control the thrombocytosis associated with polycythemia vera. However, many patients have difficulty tolerating the medication. Furthermore, some studies suggest that anagrelide may be associated with increased risk of arterial thrombosis and bleeding. Thus, the use of anagrelide has declined significantly. Interferon alpha-2b may also be prescribed. This is the most effective treatment for managing pruritus. Interferon alpha-2b is also very effective in controlling blood counts in this disorder. Allopurinol may also be prescribed to prevent gouty attacks. And lastly, low dose of aspirin may also be prescribed. Low-dose aspirin is used to reducing pain associated with erythromelalgia. Low-dose aspirin has also been shown to reduce vascular thrombosis without increasing the risk of bleeding and is considered the frontline therapy. As for management of secondary polycythemia, it is done by treating the underlying condition. These are the nursing diagnosis and intervention for polycythemia. Impaired gas exchange related to increased vascular resistance. With this, the nurse is expected to elevate the head of bed and position the patient appropriately, monitor vital signs, encourage frequent positioning changes and deep breathing, administer hydroxyurea to suppress the bone marrow as prescribed, encourage adequate rest but avoid sedentary behavior, and encourage to still do activities within patient's tolerance. Risk for ineffective tissue perfusion related to possible thrombosis. With this, the nurse is expected to obtain history of thrombosis, smoking, obesity, poorly controlled hypertension and diabetes, administer anagrelide or aspirin as prescribed, instruct to avoid smoking, inform about the signs and symptoms of thrombosis, instruct to avoid sedentary behavior, crossing of legs, and wearing tight or restrictive clothing. Risk for bleeding related to treatment regimen. With this, the nurse is expected to obtain history of bleeding, instruct to avoid over-the-counter high-dose aspirin and aspirin-containing medications because these medications alter platelet function. Instruct the patient to avoid intake of alcohol, inform about the signs and symptoms of bleeding, and instruct to avoid iron supplements and over-the-counter multivitamin supplements because the iron can further stimulate RBC production. Impaired comfort related to illness-related symptoms. With this, the nurse is expected to focus on itching or pruritus, to administer interferon alpha-2b as prescribed, recommend bathing in tepid or cool water and avoid vigorous toweling off after bathing. Recommend to apply cocoa butter or oatmeal-based lotions and bath products or baking soda dissolved in water. For gout, administer allopurinol to prevent gouty attacks. Lastly, fatigue related to disease. With this, the nurse is expected to encourage adequate rest and limit activities within patient's tolerance, encourage to gradually increase activity level as tolerated, and encourage nutritionally dense, easy to consume foods, and to avoid caffeine and high sugar foods and beverages.
What is the prognosis of patients with polycythemia? Patients with polycythemia vera have a median survival of 1.5 to 3 years in the absence of therapy. There is no cure that exists for polycythemia vera, but it can be controlled through treatment, and patients can live with the disease for many years. The overall median survival is typically 14 years, but can be up to 24 years in patients who are diagnosed before age of 60 years old. Death from polycythemia vera commonly result from thrombosis and hemorrhage. That is all. Thank you for listening.